welcome to the 8th session of the International IVF Initiative, or I3. During these unprecedented times, I3 wants to continue to provide opportunities for collaboration and continuing education to help you stay productive and in touch with the worldwide IVF community. Thank you to everyone who has joined this international initiative. As a reminder, I3 is a neutral organization with the prime mission to serve the reproductive lab community. Please continue to let us know of topics you may be interested in so that we can address them in future meetings. This webinar will be recorded and all sessions are posted on our website at ivfmeeting.com. Depending on where you are in the world, I'd like to wish you a good morning, afternoon, evening, or night. My name is David Russell from the University of Colorado in Denver, and I'm excited to be your host today. Along with me today is Dr. Cassie Roeca, the Senior REI Fellow at the University of Colorado. Cassie will be introducing our speakers and helping with the question and answer session.
Hello, everyone. Happy to be here.
Hi, Cassie. During this session, we'll be focusing on the ovaries, specifically preserving and transplanting native ovarian tissue and how to build and transplant an artificial ovary. This is truly cutting-edge technology, and we're honored to be joined today by our two distinguished speakers, Dr. Dror Meirow from Tel Aviv University, Israel, and Dr. Christiani Amorim from the Catholic University of Louvain, Belgium. As always, behind the scenes, we'll have our distinguished panelists who will be answering and handling questions through the Q&A function. Today, our discussion team also includes our very own Dr. Leslie Apia, the Division Chief of OBGYN at the University of Colorado, and head of the Fertility Preservation and Reproductive Late Effects Program. Dr. Apia is a member of the Oncofertility Consortium and has experience building ovarian tissue cryopreservation programs across the United States.
Hello, everyone. It is a pleasure to join you today.
Hello, Dr. Apia. Thanks for joining us. Also joining the discussion panel today is Dr. Yuval Young, who is the lab manager and chief embryologist at the Reproduction Laboratory and IVF Unit, Department of OBGYN, Chaim Shiva Medical Center, Tel HaShamar, Israel. Dr. Young will be able to help with lab-related questions. Hello, Dr. Young. It's great to have you with us.
Hello, everyone.
Dr. Young, if you could turn up the volume on your microphone a little bit, I think we'll be able to hear you just a little bit better.
All right.
Thank you. So as usual, we encourage everyone to ask questions throughout the presentation. Please note that all questions for our speakers must be asked through the Q&A function. Do not use the chat function for questions. Submitted questions may be answered verbally or in writing. All of the answers will be published on our website. Also, if you want to receive CEUs for these presentations, please make sure when you register you use the name you would like it to appear on the certificate of attendance. I guess some people register using pseudonyms, and so that's what's going to appear on the certificate. Before we begin, I'd like to invite Dr. Apia to say a few words.
Hi, I am honored that the University of Colorado is hosting this very timely session. Ovarian tissue cryopreservation is vitally relevant as infertility affects 1 in 10 children treated with fertility-altering treatments, and pregnancy rates are reduced by 40% in adolescent and young adult cancer survivors. Due to the urgent need to initiate treatment for many cancer diagnoses, oocyte and embryo cryopreservation are not always feasible, leaving OTC as the only viable option for these patients. I recently joined the Department of OBGYN from The Ohio State University and Nationwide Children's Hospital, where we developed a robust ovarian tissue cryopreservation program for both pediatric and adolescent young adult patients. I am very excited about the opportunity to help bring this technology to the Colorado Comprehensive Cancer Center and Children's Hospital, Colorado.
Thank you very much, Dr. Apia. We really appreciate your help during this meeting. And now I'm going to turn the meeting over to Dr. Roeca.
All right. Thanks so much, David. All right. So I think we had a poll at the beginning when everyone logged in. Thomas, do you mind bringing that up for us? All right. So the question was, does your institution perform ovarian tissue cryopreservation? So it looks like the majority of participants said no. So 61% said no. 12% said yes routinely, 19% said yes occasionally, and then 7% of participants do not work in an institution that performs fertility treatment. All right, very interesting. So it looks like the majority of people attending this session are not currently doing this, making the talks more relevant. And I think at this point, we'll actually present another poll that we can address later in the talk, if you don't mind bringing that up, Thomas. Okay, and so without further ado, I'd like to introduce our first speaker, Dr. Dror Meirow, who is live with us from Israel. Dr. Meirow is the chair of the Morris Kahn Center for Fertility Preservation, Division of OBGYN at Sheba Medical Center in Tel Hashomer, Israel. He's professor at the Sackler Faculty of Medicine in Tel Aviv University, and he's the former president of the International Society of Fertility Preservation. His research focuses on the effects of chemotherapy on reproduction and modalities for fertility preservation, especially on ovarian tissue harvesting for fertility preservation and medications that can prevent chemotherapy-induced ovarian damage. Among other things, his impressive biography includes the first report of a healthy live birth from transplantation of cryopreserved thawed ovarian tissue into a sterilized former cancer patient. So with that, Dr. Meirow, we are very pleased to have you, and you have the floor.
Okay, thank you very much. Let's turn on. One second. Do you see it now clearly?
Looks great.
Okay. So the topic that I will mention now is the cryopreservation and transplantation technique for fertility preservation, and I'll focus on clinical management, success rate, and actually many techniques that are involved. There is nothing for me to disclose, and I added also Dr. Yuval Jung disclosure, so we don't have anything to disclose. So when we deal with fertility preservation, there are several indications on cancer patients that are treated with chemotherapy or radiotherapy, or non-cancer indications that receive chemotherapy treatment. And actually, these are the most frequent indication for ovarian tissue freezing. But there are also gynecological patients, and we have patients with accelerated follicle loss, like with genetic disease, like the Turner syndrome and galactosemia. And there is, of course, the fertility preservation for age-related, what we call social egg freezing. We have started our transplantation results with our first publication in the New England Journal of Medicine, that we had a patient with documented ovarian tissue, ovarian failure after bone marrow transplantation. And we have very tight monitoring on this patient before and after a transplantation of the ovarian tissue. And after transplanting the ovarian tissue, we had the endocrine function, we performed IVF. This was the first IVF performed after transplantation of ovarian tissue, and we have achieved the pregnancy with the proof of concept. But nowadays, years have passed, and there are several methods to preserve fertility. One is the ovarian tissue freezing, but one more commonly used is oocyte and embryo freezing. And in order to make a decision, we have to see the results of these options. And as I said, I will focus on ovarian tissue freezing. So from the beginning, and we started decades ago, we had until 2019, we have more than 600 patients that underwent ovarian tissue freezing. We looked at the mortality rate of those patients, and we had 10% of those patients died from their disease. And we have performed until 2019, 43 patients underwent transplantation. If you look at the indications of those patients, most of the patients are hematological malignancies, but we had also breast cancer, solid tumors, and some gynecological disease. If you want to look on the ages of the patient that ovarian tissue was cryopreserved, So we have very young children, almost babies, but most of the population are young adults, and we freeze ovarian tissue up to the age of 40. We looked on patients that received chemotherapy prior to tissue harvesting, and we can see that quite substantial number, especially on certain diseases like in the leukemia and other hematological indication, received chemotherapy prior to tissue harvesting, and this will be an important part of my talk. So when we look on this, what happens clinically on cancer patients, many of them will come for fertility preservation prior to high-dose chemotherapy like bone marrow transplantation. Some of them will not receive chemotherapy before, but some of them will just had some chemotherapy treatments either a few weeks before or a few months before coming for fertility preservation, and some of them months or years. We have published already in 2013 in Fertility Sterility, based on animal studies, that we do not collect mature or immature eggs for fertility preservation in patients recently exposed to chemotherapy because of the high risk of genetic abnormalities in those oocytes. There are also centers that freeze oocytes for young children. If you don't look to the how you perform it, but you look in the eggs. So there is a very nice publication in Science that came just half a year ago, showing the high level of chromosome errors in human eggs that were taken for very, very young age. So this is also another limitation that might come for freezing oocytes for children. So now let's switch for ovarian tissue transplantation. In order to have the success rate, there are many factors that are involved. The tissue, the amount of tissue that you take, what is the ovarian reserve of this patient, what are the graft dimensions, and the freezing conditions. And then when you go to transplantation, where is the site, the vascular bed, there's some kind of follicle activation that I might talk about it during the talk afterwards, and the operative technique. So looking on preparation of the tissue for freezing, this is the size that we commonly use, prepare the tissue 0.5 over 1 centimeter or a little bit less of ovarian tissue, 1 to 2 millimeter thickness. But there are publications like, especially from Sherman Silver, usually for fresh tissue, that he uses a very large ovarian tissue fragments, but this is really not for freezing, but for fresh, or a very small fragment that are also commonly used by other centers. And we have looked in animal study and showed that when you have very small fragments, you have actually follicle activation, and at the end, the amount of follicle remaining is much smaller than if you have larger fragments of ovarian tissue and you have less activation, and at the end, you are staying with more follicles around. So that's the reason we use the size that we use. What about the freezing protocol? All reports that I will show now and all the results are coming with the slow freezing protocol. And I gathered that 3 centers that actually were the first to report on transplantation and live birth after ovarian tissue transplantation. And then this is the center from Jacques Donnet in Louvain, Belgium, and Sherman Silver from St. Louis, USA, and our center. And if you can look at the preparation of the tissue, the medium, actually the protocol and the freezing protocol, they are very, very similar. What is the maximum loss of follicles that is caused by all this procedure? We are losing almost 80% of the follicles, but this comes mostly at the end. We lose most of the follicle post-grafting, and not so much, but all the other steps before. So let's look what we do for the transplantation. all transplantation that I report and other centers report with live births are transplantation that were performed in the pelvis, not heterotopic, not in the arm, not in the abdominal wall, but in the pelvis. And either they're performed into peritoneal sacs, as you can see here, or they are performed into the ovary. And here in the ovary, there are two options. The one that we report into a subcortical tunnels or pockets, as you can see here, and I will show soon, or to replace the atrophic cortex, as was shown by Jacques Donnet, that you replace the atrophic cortex with the fragments that you transplant, and you can see here. So I will show a very short video of a mini laparotomy that we performed ovarian tissue transplantation. And you can see here that a tunnel was made below the atrophic cortex, and you just put the transplanted tissue, and that's it. It's very, really simple and very short. Afterwards, you can either get a spontaneous pregnancy or IVF pregnancy, and I will show here. This is a stimulated ovary after transplantation. You can see the endocrine response, and we use either natural modified cycle or conventional stimulation with antagonist, but this is according with the endocrine function and sonography. So this has been performed since 2005. And now I want to present data that will very soon come in fertility sterility, maybe this week or next week. And we report the ovarian tissue transplantation results from 3 centers with more than 15 years of experience. And we also were using very strict criteria in order to know all data of this patient. Only those patients were included. And the results are coming for our center, from Shiba Center, for the Université Catholique de Leuven by Marie-Madeleine Dolmans that gave us the results, and from Professor Sherman Silver from the Infertility Center of St. Louis. And these are the results. We had 70 patients that had transplantation of ovarian tissue, 87 transplantations, but after having all those strict criteria, we have 60 patients that were included, and we got astonishing results. Menstruation resumed in 94% of patients, at least one pregnancy, 50% of the patients, and at least one delivery, more than 40% of the patients. And we had many patients that had repeated deliveries. So we had prolonged endocrine function, prolonged fertility, and repeated pregnancies after having really strict criteria for looking all data of these patients. And now we wanted to look on details of this group. So what happens if the patient were recently or before exposed to chemotherapy? When you use this and you look into the results, you see that actually there was no difference in patients that conceived if they received or did not receive chemotherapy prior to tissue harvesting. And this is very encouraging. And if you look on other parameters, so in our group, in graph dimension, there was no difference, although I mentioned here that animal studies show differently and maybe the group is not large enough. Transplantation site only in the pelvis, there was no difference if it was in the peritoneum or into the ovary. The surgical approach, either laparotomy or laparoscopy, no difference. Pre-harvesting chemotherapy, as I said before, no difference. The younger the patient, there was trend for higher pregnancy rate, and this is obvious because of larger ovarian reserve. And if we look on cancer patients that underwent oocyte freezing, and this comes from the group of Evie that was published in Fertility Sterility almost 2 years ago. So the number of patients was about 50 patients, and pregnancy rates was 40%, and live birth rates of 32%. So this, I think, showed the strength of this procedure. But there is the question of the safety. And this is highly important, not to put ovarian tissue that contains cancer cells. So in order, we looked on this topic for actually from the beginning of our ovarian tissue freezing, I'd say, way that we go for so many years. So our first publication of ovarian tissue freezing was in '98. And since then we asked the question, is it safe? In 2008, we reported a way of searching evidence of malignant cells contamination in ovarian tissue stored from hematological cancer patients. And indeed, you can see that there are diseases that have high risk or a low risk, and there are publications all over the world that are reporting the risk of cancer cells containing into the ovarian tissue. And as I showed you before, we have transplanted on all of these diseases, but I want to touch now the leukemic patients that are the most risky population. So what we do routinely when we freeze the ovarian tissue, we take some part for histological evaluation, looking for cancer cells. But what is more important, we freeze ovarian tissue for future evaluation. And now when the patients come for transplantation, we look into two things. First, we like to freeze the ovarian tissue when the patient is in full remission. And this is the reason why our leukemic patients were exposed to chemotherapy before harvesting the ovarian tissue. Actually, this is the routine. This is the best time because the first treatment for leukemia is not so much sterilizing. And now before the bone marrow transplantation and the patient is in full remission, then we perform the ovarian tissue. And second, prior to transplantation, we use all techniques that are available in order to look for cancer cells. And with this, we have reported the first delivery of leukemia survival after transplantation of ovarian tissue in 2018. And since then, we have several patients that underwent transplantation of leukemia and delivered. So having all this together, with all the world results coming and our results and now the upcoming publication in fertility sterility, I think it's time to move for the procedure not to be experimental. And actually in Israel, ovarian tissue cryopreservation and transplantation are no longer experimental for more than 2 years, and it's all fully covered by the government. So to conclude, ovarian tissue freezing and transplantation is highly effective and robust fertility preservation procedure, should more commonly be practiced. And actually I can ask, maybe we can consider it for non-medical fertility preservation indications. We are having quite a lot of fertility preservation hands-on courses. I think we had more than 13. And to conclude, I really want to thank the group that are working with us, especially my teammate, Dr. Hilara Nani, which is working in the fertility preservation program, and the IVF program with Professor Roeca, an advisor, which is the head of the lab. We have the very large fertility preservation research and looking for cancer cells. To give us the strength for this procedure is the Cancer Research Center and the Shiva Pathology Institute. Thank you very much.
All right, thank you, Dr. Meirow. That was wonderful. We really appreciate it. We do have some questions from the audience for you. So Dara Berger is wondering, how long can the tissue be viable from the biopsy until it's transported to the lab? And how are you transporting it? What temperature?
Okay, we are lucky because actually we freeze the ovarian tissue adjacent to the lab. So we don't need any transportation of ovarian tissue. There are publications from Europe that use transferring ovarian tissue from country to country, from town to town. We don't need it. Also, Israel is very small, but they have conditions and report about 24-hour transplantation. I don't have the protocol now with me, but it's well published.
Okay, wonderful. And then Sungtae Kim is wondering how long you can expect to have endocrine function from the transplanted ovarian tissue.
Actually, this is variable, and I can say that we did not expect so long period of ovarian function. When I mentioned the repeated pregnancy, we have few families with 3 kids after single transplantation. We have one family with 4 pregnancies after single transplantation of ovarian tissue. So it can be for many years, but sometimes we had a transplantation with 1 pregnancy, and then we had to repeat transplantation in order to achieve the 2nd pregnancy.
Okay. And then another question here, kind of pertaining to the risks. D. Kinney is wondering if any of the centers that you had discussed, if any of the patients have gone on to develop ovarian cancer, to your knowledge, after the cryopreservation transplant?
Yes, we look very well into this, and actually there's only one report from Australia about a recurrence of a cancer after transplantation in patient which actually had ovarian cancer, and there are some reports of ovarian of disease recurrence after transplantation of ovarian tissue. This from the group of Andersen from Denmark, but they looked into this carefully and said that actually the recurrence was not related to transplantation.
Okay. All right. Thank you very much, Dr. Meirow. I do want to go back to the poll that we presented before your talk. So we asked, would you consider oocyte or embryo freezing for fertility preservation prior to sterilizing treatment in cancer patient that was recently treated with chemotherapy agents? So 77% of those polled said yes. Dr. Meirow, do you want to speak to that quickly?
Yes, I heard it also when I came to one of the SRM meeting. There was a presentation from a center from the South that presented that they will perform a oocyte freezing after a patient received a few weeks or months ago chemotherapy. First, the response rate is very low, but this is not the most important thing. The most important thing is that according to animal studies, there is big hazard of genetic influence. There was a study that we performed together with Roger Gosden years ago, and we looked of abortions and malformations after recent exposure to chemotherapy, after the eggs were recently exposed to chemotherapy, and we got more than 30% major malformations, and we got up to 80% abortion rate. So I think it's really, really something that you should not use. I all the time advocate for this, but many centers has only oocyte freezing procedures. So they said, what can we do? But really, you should switch to, in these cases, for ovarian tissue and not make oocyte freezing.
All right. Well, thank you again, Dr. Meirow. All right, and we're going to move on to our second speaker, Dr. Christiani Amorim. Before I introduce her, Thomas, can we bring up our final poll for the audience? All right. So we are very pleased and lucky to have Dr. Christiani Amorim with us. She is professor in Belgium. She received her PhD from the Federal University of Santa Maria, and she previously worked at Florence University in Italy and then Brasilia University in Brazil. So currently she's professor at the Catholic University of Louvain in Belgium, where she's been focusing her attention on the development of a transplantable artificial ovary to restore fertility in cancer patients. She also serves as Basic Scientific Officer for ESHRE's Special Interest Group on Stem Cells. She's a board member of the Society of Low Temperature Biology and an Associate Editor of Human Reproduction Update and Journal of Tissue Science and Engineering. So Dr. Amorim, you have the floor. We're so happy to have you here. Thank you.
Thank you, Cassandra. Well, good evening from Belgium. Let me share my presentation. Well, good evening, everyone. Before I start, I'd like just to congratulate I3 for this brilliant initiative to set up these sessions in such a trying period. And I'd like to thank for the kind invitation to be part of this session together with Professor Meirow. This is a very exciting occasion for us. Well, more than 600 people here, this is amazing. A lot of people from Brazil. Olá, todo mundo. Muito boa noite. Professor Meirow just talked about the reality that we have now for cancer patients for cryopreservation and transplantation of ovarian tissue. I'm going just to talk about a strategy that is not available right now, but is under development for one group of patients that I'll explain later. So first, I'd like to say that I have no conflict of interest related to this presentation. So as Professor Meirow mentioned, we have many countries currently doing cryopreservation and transplantation of ovarian tissue. Among one of these countries, Belgium, we are one of the pioneers in this technique. This is a very good strategy to preserve fertility in prepubertal girls and women who has to start the cancer treatment as soon as they are diagnosed with the disease. As he mentioned, we have a restoration of endocrine function of almost all patients. Right now, we have more than 150 live births worldwide. So this is a quite robust technique. I agree with him that this is should not longer be considered experimental technique. But there is still one group of patients, of cancer patients, that we cannot help. Professor Meirow mentioned that in Israel, he performed transplantation of ovarian tissue in leukemia patients. In Belgium, we are not allowed to do this because, as he said, the risk of ovarian metastasis. So in types of cancer like leukemia, neuroblastoma, and Burkitt lymphoma, we are not allowed to transplant ovarian tissue. We cryopreserve the tissue, but the tissue remains there. And for these patients, we don't have any current strategy to restore the fertility. So what we can do for these patients, there are two main strategies under development. One of them is the in vitro culture of preantral follicles. Professor Telfer talked about this last week here in the I3 session. If you didn't see the session, you must see it. It's really, really, really good. It's recorded and you can find it here in the website together with the presentation also from Professor David Albertini, which was also very good. We don't do in our lab in vitro culture of preantral follicles. What we're trying to do is to try to isolate these follicles and put them back to the patient. So we are trying to develop a transplantable artificial ovary for these patients. So the idea that we decide to go through this different path is that we believe that by transplanting these isolated follicles, we can offer not only live birth, well, this will be just already good enough, but just like the ovarian tissue, we could restore ovarian function of these patients and give them the opportunity to have a natural conception, just like what we have with transplantation of ovarian tissue. We also thought about this because in our hospital in UC Louvain, we have a very good experience with transplantation of ovarian tissue, so we thought we could take advantage of this too. what we have been learning this last years working on the development of an artificial ovary is that the follicles, they cannot survive and live by themselves. So they need the surrounding ovarian cells and extracellular matrix to survive and grow. So we know through the literature and our own experiments that the ovarian cells are in constant crosstalk with these follicles for their activation and growth. Some of these cells will be recruited to differentiate into T cells. And these cells also synthesize extracellular matrix. And this extracellular matrix, in turn, it's necessary for the 3D support of the follicles. We know that primordial follicles really need a sort of a rigid structure to continue surviving. And they also provide biomechanical and biochemical cues that are essential for the follicles. So this is, we thought when we start the concept of the artificial ovary. So the patient comes to our center, like she's there at coming. Before the treatment, we cryopreserve the ovarian tissue. Once they're cured, we can thaw the tissue. We safely isolate the follicles. At the same time, we remove a biopsy of the remaining ovary, the ovary that went through the chemo or the radiotherapy. There are no follicles there, but there are still cells inside. So we can isolate those cells. And we can put them together with isolated follicles in the three-dimensional matrix. And then we transplant this structure to the patient. So in the last 12 years, we have been focusing our attention on these three main points: how to safely isolate a high amount of these follicles, how these cells will behave after isolation in this 3D matrix, and which is the 3 matrix that we should use to transplant these follicles and cells. So I'll briefly go through these 3 points just to give an overview of what we have been doing and where we are now. So for the follicle isolation, we have several PhD students that try to come up with a safe isolated method that can preserve the structure of the follicles, but at the same time was able to separate these follicles from a possible contamination with malignant cells. So now I can tell that we have a protocol for human parental follicle isolation that can be applied in clinical setting because we use a GMP-produced enzyme. This protocol can be personalized according to the ovarian tissue properties, so we can modulate this procedure according to the tissue that from the patient. And it's a safe procedure for isolation of these follicles regarding reintroduction of malignant cells that would be present in ovarian tissue. So the other point that we were working on, it was the population of ovarian cells. Our studies show that when we isolate the cells from the ovary and we put them in the matrix and transplant xenografted to mice, we can see that these cells, they can proliferate. They are able to form an ovary-like structure. They degrade this 3D matrix and they synthesize their own extracellular matrix. And when we increase the population of endothelial cells, we have an improvement of vascularization. So the pictures that you can see here is just a group of isolated ovarian cells together with endothelial cells from the ovary that we put in the 3-dimensional matrix. And after 1 week of xenografting mouse, as you can see in red, these are all the vessels that are already formed throughout the matrix. Only one point that was still missing, and this was the last point that we solved regarding ovarian cells, it was their differentiation in T cells. As we know, we know a lot about the oocyte and granulosa cells, but we don't understand much about thicker cells. We don't know the origin and how they are recruited and how are they stimulated, they get to be differentiated. So we know we have a few new studies in mouse, but we don't know if we can believe that this process of recruitment of T cells in human ovary would happen in the same way as in mouse. So we don't know if there's a specific group of T precursor cells in human ovaries, or as they have studies in bovine ovaries that all ovarian cells have the potential to become T cells under the right stimuli. And of course, what is the most important for us, if this process would happen in the artificial ovary, because without Theca cells, the follicle cannot continue to grow. So we had a few experiments in our lab in the last years that we isolated ovarian cells from ovaries from postmenopausal women. So we are sure that there was no follicles there, just pure ovarian cells. We put these cells in culture in different conditions with some supplements that we believe would help these cells to differentiate. And after 1 week or 8 days of in vitro culture, 43% of the cells were able to differentiate into Theca cells. So this is a very important result for us, because we know that these supplements that we add in the medium were supplements that could be produced by follicles during their growth. So once we put these isolated follicles in the artificial ovary, once they start growing, they start synthesize these growth factors that would permit the recruitment of these cells. So we know now through this study that there is a subpopulation of Theca precursor cells among stroma cells in human ovaries. We don't know which are these cells yet, but we know they remain in the ovary until after postmenopause. And of course, we believe that Theca cell differentiation is likely to take place in the transplantable artificial ovary. So the last and the most challenging point for us has been which matrix we should use to transplant these isolated follicles and cells. We have been working with different polymers. We start finally having good results with alginate, and then we have even better results when we grafted these follicles with fibrin, which is a natural polymer. The results were quite interesting. We have a recovery rate of human isolated follicles after 1 week of xenografting around 22%. It looks quite low, but when you compare with the first studies of xenografting of human ovarian tissue in mouse, also for 1 week, the recovery rate of follicles was 27%. So we are not really far from those results, but we believe there is still a lot of room for improvement. So we know that fibrin is very easy to work with, it's biocompatible, is FDA approved, is biodegradable, it has a very good mechanical support, but we are missing some biomechanical and biochemical cues that we have in the extracellular matrix of the ovary that we cannot have with the fibrin. So the idea that we have in the last years is to first stop a little bit and try to understand the human ovary in order to construct an artificial ovary. So if you see in the literature, there's not much information about human ovary. So we start trying to dig in to get information about this biochemical cues. So the first paper that we had on this topic, it was published last year, where we had a very interesting result on the metrisome of the human ovary. We could identify more than 100 proteins. Most of them belong to the core metrisome. So we know that now the human ovary is made of 48% of different types of collagen. We know that the most abundant type of collagen in human ovary is collagen type 6. There are different glycoproteins, proteoglycans, and we have a lower proportion of matrisome-associated proteins. Regarding the biomechanical cues, we also have that we'll have a publication coming out in the next weeks, where you also see how these collagen fibers change during the evolution of the human ovary from the prepubertal stage until postmenopausal stage. And you can see here in the figures that the concentration, the type of collagen fibers completely change during all the period of the woman's life. And what was most intriguing for us to observe is that the ovary becomes more rigid with age comparing to prepubertal women or girls, but surrounding primordial follicles in prepubertal ovaries, it's much more rigid than surround the the perifollicular area in women at reproductive age. So this is quite interesting for us, and we believe that these also play a role in the activation of a primordial follicles in the different stages of women's life. So we thought about stop working with fibrin for the moment and maybe focus our attention in the ovarian decellularized ECM, because there we could find these biochemical and biomechanical cues. First we thought, why not to use the decellularized ECM, like there are so many studies in different organs. The problem is that, as you can see, this is a decellularized ovary, and you can see that it's not really easy to seed isolated cells and follicles, because the pores are completely different regarding the pore sizes of follicles are completely different. So you cannot really fit in the follicles where they should be. So we thought maybe this is not the best idea, but how we could still benefit from this decellularized ECM. The idea that we had was to make an hydrogel from decellularized ovarian ECM. This is a strategy that has been published for many different tissues and organs, and there are many different products already available, commercially available, and we thought this could be a good alternative for us. So just to conclude this presentation regarding the artificial ovary, I can tell you that now we have a protocol available to isolate these follicles. We know that when we introduce these isolated cells, we can have vascularization in our matrix. Some of these cells will be recruited to differentiate into thicker cells. We can have quite interesting results when we transplant these follicles and cells in fibrin matrix, but we know that we need some information on human ovarian tissue to really develop a biomimetic three-dimensional matrix for the artificial ovary. So finally, I would like just to thank you to be here. Well, more than 600 people, it's quite interesting. And of course, all our team in the gynecology lab here in UC Louvain. Thank you.
Thank you so much, Dr. Amorim. That's very, very impressive. Appreciate you sharing that with us. So a lot of people are wondering, how close are we to having an artificial ovary? You know, when can this be put into clinical trials, and what are your thoughts on that?
That's a very good question. We still have many years. When you think that we're still working with different organs for like artificial hearts and artificial lungs that are there under development for more than 20, 30 years. We know that this is not a technology that we can have available next year, unfortunately.
A lot of work. It sounds like it is a lot of work. Very wonderful. Thank you. We have a question from actually the Johnson Lab here at University of Colorado, that after you've isolated your primordial follicles, which activators are you using on those primordial follicles?
It's not necessary. The follicles, they can activate by themselves once they're isolated. So it's just like what we observe when we transplant fragments of ovarian tissue.
Okay. And then what other growth factors potentially could you be using, like TGF-beta or anything like that, along with the extracellular matrix for the artificial ovary success?
In the beginning, we thought about adding some growth factors, but when we start looking at the last years in tissue engineering progress, people are trying to use less and less growth factors because they're very difficult to work with. We don't know how, for the duration of the activity, how they really behave. They are it's completely different than putting the medium in culture. So the idea is just to put the cells, give them environment that they can feel comfortable to behave like they would behave in the ovarian tissue.
Okay. Wonderful. And then we do have some people curious if you would be able to start working on creating the artificial testicle.
There is another group in our unit that have been working on this. That's the group of Professor Christiani. They have been working on the artificial testes. Yes.
Okay, wonderful. Thank you so much, Dr. Moram. So I want to bring up the results of our latest poll. So we asked, what method of cryopreservation do you use for ovarian tissue cryopreservation? So about 50% said, not applicable. And then it's pretty much split. So 27% vitrification, 24% slow freezing. Dr. Moram, I know that you've published quite a bit on vitrification for ovarian tissue. What are your thoughts on that poll?
When vitrification started, the first publication on vitrification, the results were quite exciting. We also decided to test vitrification. We had some interesting results. We did some studies with baboon model that is quite similar to human. We follow up the animals after vitrification transplantation of ovarian tissue for 1.5 years. For this period, we have follicular growth, we had ovulation, we have estradiol production, but none of the animals never became pregnant. So I still have my concerns about vitrification. There is still that's a quite high concentration of cryoprotectant. This makes me quite uncomfortable.
Okay, thank you for that insight. All right, David, I'll pass it back to you.
Okay, thanks, Cassie. So I just wanted to say thank you to both of our speakers for fantastic presentations. And now we'd like to continue our discussion with more questions for our speakers and our panelists. And actually, to start with, I have a couple questions for Dr. Young. Dr. Young, since a large number of our participants today are on the lab side of the equation, could you describe how technically challenging the freeze and thaw procedure is for ovarian tissue cryopreservation, and how the ovarian tissue freezing procedure fits into your day-to-day operations in the embryology lab, especially since these procedures are often take place at short notice?
Hello, hi everyone. Can you hear me well?
No.
Can you hear me better now?
Yes.
Okay, good. So for the procedure of thawing and freezing, the thawing is quite easy one. Just the piece that you thaw, just you have to put it in 3 different mediums, and it's ready for 5 minutes each, and it's ready for transplantation. But the freezing is more challenging because you need to take the piece of ovary and take out everything but the piece where all the primordial follicles, the cortex. And take out all the medulla, and it might take a while, and it's easy and very delicate procedure. And that's why it takes a little bit more time, and it's challenging, but it's something that you need to practice till you get it done well. About the routine work, in Israel, we just use a slow freezing, which take time, about 3 hours, the total freezing procedure. So because of the emergency, sometimes we need to stay longer time in the lab because of it.
Oh, thank you very much. So just kind of in summary, when you are doing this procedure, from when you get the tissue sample until you actually finish the freezing process, about how long does it take?
It takes about between 4 and 5 hours.
Okay, thank you very much. Cassie, I'll turn it back over to you.
All right. So I have a question for Dr. Appiah. You know, we know that this technology has been shown to be effective. It's a viable option for so many women, but it's perhaps underutilized. And can you explain what does it entail to start an ovarian tissue freezing program from scratch, and how many parties are involved? How long does it typically take?
Absolutely, and thank you for the question, Cassie. So many of us on the webinar are well immersed in the field and therefore very familiar with the benefits and successes of ovarian tissue cryopreservation. However, to many institutions, this is still quite novel. Consequently, the greatest obstacle to overcome are stakeholder engagement and then streamlining the process. So stakeholders typically include hospital and cancer center leadership, a gynecologist, urologist, reproductive endocrinology and infertility specialist, and a patient navigator to oversee the processes. Attaining stakeholder buy-in will expedite the process, will decrease costs to the patient, and improve knowledge of ovarian tissue cryopreservation throughout the institution. This will in turn increase financial and strategic support for the program. And then once you have engagement, harvesting and processing the ovarian tissue is straightforward once the protocol is established for your lab, and then becomes a matter of just streamlining the process from start to end. I would say that establishing a program in the United States can take 1 to 2 years, depending on available resources. May take a little bit longer if it's being done under an IRB protocol. And for the audience members, we have a step-by-step procedural guide that we are happy to share with attendees.
All right, wonderful. Thank you so much, Dr. Appiah. I'm gonna open up some questions for the panelists, and feel free to discuss amongst yourselves if you feel you have something to add or want to add. So one of the themes that's coming up in the questions is there a cutoff for AMH or FSH that makes sense when you're considering, you know, who should undergo ovarian tissue cryopreservation?
Okay, if it's for me, no, we do not measure AMH levels prior to ovarian tissue freezing. I have to mention, when a patient was recently exposed to chemotherapy, actually there are no any measurement that you can have or use to identify the ovarian reserve of the patient, because sonography will not show antral follicle, and blood levels of neither AMH, FSH, estradiol will not be helpful. Only your knowledge about the age of the patient and what she was exposed to. These are the most important parameters. And our age goes between 1 year to up to 40 years. We have a pregnancy at the age of 38. So that's the reason it was twin, that's the reason we do it up to 40 years old. But the younger the patient, the higher the results.
Okay, thank you very much. So since we're doing this in the time of COVID, there actually is another question about COVID here. It's from Yona Barrick, and the question is, since it was found that ACE2 receptor is present in the ovary, what is your opinion of preserving ovarian tissue? Should we do it now or wait until the pandemic is stabilized? Dr. Meirow?
The only thing that was said by worldwide organizations and actually by the Health Ministry of Israel was that fertility preservation for cancer should continue during this pandemic. And we do all procedure for fertility preservation in cancer patient. Still, we have breast cancer patients that go oocyte freezing or embryo freezing, and we have patients with other diseases that will go for ovarian tissue freezing. and we didn't stop doing anything. If something in the future will be found, something solid that will say that we cannot use it, maybe, I'm not aware of it, but at this point, I think it's mandatory for us, because the patients continue treatment, that we do all options available to treat our patients.
Okay, great. Would you be storing the samples that you would be cryopreserving now any differently at this point?
At this stage, we do not put them in a different place.
Okay, thank you. I have another question here, and this one I think maybe Dr. Appiah could answer. It's from Elizabeth Ginsburg, and she said, many patients after chemotherapy are not sterilized and are fertile. So how do you choose which patients are candidates for ovarian tissue cryopreservation? And also, many patients have elevated FSH levels and low AMH levels after transplantation, perhaps worse than after chemo alone, for example, breast cancer.
Sure, and I think Dror answered this as well, that although some of us have drawn FSH levels and AMH levels, really after treatment, it's hard to kind of understand what those levels mean. So as Dror mentioned, really looking at the chemotherapeutic regimen that the patient received. If it's a non-sterilizing dose, then transplantation based on Dror's research and several, Silver's research shows that there is viability. So I don't know that we could actually look at lab work because there are abnormalities after chemotherapy.
Thank you, Dr. Appiah. All right, and we have a question from Oleski Pravdiuk, wondering what was the longest period of ovarian tissue cryo storage that resulted in a successful pregnancy, according to your own experience, Dr. Meirow?
I think it was 12 and a half years that the tissue was stored until we transplanted it. And the patient conceived and delivered a healthy baby.
Okay, wonderful. And I have a question here from Karina Meirow. She's curious, what do panelists think about using this technique in menopausal patients?
I'll answer. I've heard from many women that they think this would be a great idea, and there's a lot of discussion about that. I personally think it would be great. I think we have to be sure that that tissue that's being transplanted is not a type of tissue that's going to have an increased risk of malignancy. But I know there's some concern, and I know Dror is going to probably state this about neovascularization when we transplant the tissue into, let's say, the abdominal wall, and whether or not that tissue is going to be as viable. But I think if we could have that technology, it'd be great for patients.
Thank you. It looks like Dr. Amorim has something to add too.
If I had 25 years old, I would do it. I would freeze my ovary for this. I think that this could be a quite promising alternative, and if we see the results of grafting from Professor Octay, that he grafted tissue under the skin and he still can have follicular function, why not consider this type of transplantation for these patients? I think that this could be something that could be studied for this purpose.
Okay, thank you. This question might be good for Dr. Meirow. We have a question from Evelyn Yarena Carey, and she says, if the number of menstrual cycles is dependent on the number of primordial follicles in the ovarian tissue section, is there a way to know in advance how long a woman will recover her ovarian function?
I don't think so, and this is quite. I don't think that the number of primordial follicles that we count in the fragment should be parallel to the number of primordial follicles that exist in the ovaries, because I think that the biological clock changes. And if, for example, every month a woman loses 1,000 follicle in normal life, when you have only the residual fragments that are transplanted that obviously have very few follicles, the number of follicles that are recruited and die and goes through the process of atresia is much smaller. And as you can see, we have those small fragments that lasted for 8 and 10 years, and obviously the biological clock changes.
Thank you, Dr. Meirow. So as we get close to wrapping up here, we know that ASRM did recently lift the experimental label on ovarian tissue cryopreservation, and we know that over half of the people tuning in today are not performing this at their institution. So what final words of encouragement do you have to start making this accessible within people's programs going forward?
I will answer
Okay.
that. Oh, go ahead.
Yeah, sure.
Go ahead. Go ahead.
No, please.
Sure. I was going to say that I think there's no reason to reinvent the wheel. There are several centers across the United States and abroad who have done this and done this well. So I think to minimize the length of time that this can take, to reach out to a colleague and get assistance in building your program. There are a lot of pitfalls that one could become ensnared in. So I would say reach out to colleagues.
Anything to add?
I want to add that all the time there was a question, what is the efficacy of this procedure? And I think this is the reason that we, Marie-Madeleine, Sherman Senior, and myself put together the effort to make this manuscript that is coming out now in Fertility Sterility, to show that really it's not only robust and simple technique, but it's a very highly effective, very strong tool for fertility preservation. So maybe now with these results, people will be more encouraged, and with the SRM decision to open a center of ovarian tissue freezing, more centers. Okay,
thank you, Dr. Meirow. Dr. Amorim, do you have anything you'd like to add before we close?
No, I'm just would like to thank you again for the kind invitation, and this is really wonderful to be here.
Okay, thank you very much. We really appreciate it. So I think we're going to wrap it up now, but we'd just like to really thank the audience for all of the excellent questions, and to our speakers and panelists for the informative discussion. And once again, I'd like to thank the founders of this initiative. Your vision and hard work has really paid off in these great educational sessions. And again, I'd like to encourage everyone to contact us if you'd like to create or submit some website content, or if you have ideas about topics for future presentations. Please spread the word about I3 and let us know if you'd like to host a session. And the 9th session is going to take place next Tuesday, April 28th. And the session is going to be titled, Get Your DNA Fragmentation Out of My Uterine Microbiome. So we hope everybody stays safe and healthy, and we hope that you all join us on Tuesday. Once again, I'd like to thank Dr. Roeca, our panelist, and our 2 great speakers today. And also thank you again to all of I3 for all the hard work. We'll see everyone again next Tuesday. Thanks and goodbye.
Bye.
thank you very much.